The other thing that we can do, even with when we're assessing a hip, is do a cervical spine rotation. We can put the patient through cervical spine rotation, see what happens in an upright position, and then put him in a long sit and assess the hip contribution to cervical spine rotation. That idea comes all the way back to 3 months of age when we start talking about muscle chains, which we haven't really addressed in our discussion. We've addressed the anatomical action of muscle chains, but we haven't really addressed the functional action of muscle chains. And we probably should get into that at this point. So what I'm addressing here is when we assess cervical range of motion, bilateral rotation, and the hip's relationship to that. When an infant, while lying prone, gets to 3 months of age and they get full elongation of the spine, we engage the abdominals because the abdominals are going to act as elongators. When our abdominals engage, our lordosis reduces. As our lordosis reduces, it increases our ability to get external rotation of our hips. When that happens, we get pure rotation of our cervical spine. So if we are hyperlordotic in the lumbar spine, if our hips are in internal rotation, we're going to have loss of pure rotation potentially in the cervical spine. So the idea is that when we go in the long sit, we take out the pelvis and now we retest rotation. If the rotation improves in long sit, I'm thinking I've got a hip contribution to that cervical spine deficit.